as more low-dose computed tomography lung cancer screening programs are implemented, more patients with early-stage lung cancer could benefit from surgery are identified. And as VATS lobectomy has been associated with decreased preoperative morbidity and mortality and similar rates of cure compared with open surgery, VATS lobectomy has become the standard of care in early-stage lung cancer. VATS lobectomy is not my cup of tea, but I was more interested in my life to do major procedures in lung cancer, but all my trainees have developed a VATS lobectomy in early-stage non-small cell lung cancer. And I would like to say that I am not convinced of the advantage of VATS lobectomy, but I let them to do VATS lobectomy. It's normal. It's a new generation. It's not my generation. But my first job was gynecologic obstetrics. And I learned video when I was a young resident in gynecology. What I learned from that is that the security of surgery is not the same as an open procedure. And I learned many things in my life, and especially because I was a legal expert in France for problems in courts. And I saw some complications of video-assisted thoracic surgery, sometimes disasters. But when I read the complications of VATS lobectomy, they don't exist. There is always a difference between what is said and the truth. If I am an old surgeon, I'm 67 now, I have stopped surgery, I'm the director of the hospital, but I look at my trainees, who are excellent surgeons, and they do VATS lobectomy, and they tell me there is no advantage, but it's commercial. If we don't do VATS lobectomy, the other will have the patients. Compared to VATS, open surgery has the advantage of allowing the surgeon a more accurate exploration by using palpation and the ability to perform more complicated procedures than expected, requiring a larger approach as vascular or bronchoplastic procedures, extensive lobectomy, extensive lymphadenectomies, or to deal with the more complicated lung resection because of the absence of a fissure, an anatomical abnormality, a sclerotic pedicle, and so on. It is usual to oppose both procedures. In fact, in practice, they are not so different from each other. One must understand that VATS procedure is not a totally video thoracoscopy, since a thoracotomy is required to extract the specimen, and this aperture is often utilized to work inside the chest cavity. In open surgery, it's now the rule to use muscle-sparing thoracotomy and short thoracotomy by benefiting from all the new sophisticated tools and devices developed by VATS surgery. Both techniques need the same thing: lateral positioning of the patient, double lumen ventilation, and chest tube drainage, which is painful during the postoperative course. Finally, the postoperative course of a patient treated by VATS or open lobectomy for T1 non-small cell lung cancer are not so different if we respect the use of modern postoperative management, including the epidural analgesia. The advocated advantages of VATS are less postoperative pain, preservation of pulmonary function, shorter hospital stay, quality of life, cosmetics, shoulder function, and less immunosuppression, which would explain a better survival rate. Are you sure? Is this true? In my opinion, there is probably an advantage in terms of postoperative pain, but I am not very sure. The pulmonary function is the same after VATS as after thoracotomy, except in the immediate postoperative course, because it's pain-related. The hospital stay would be shorter, but randomized trials comparing some patients are missing. In my hospital, we underwent a new program of rehabilitation for lobectomy, and the patient leaves the hospital 3 days or 4 days after surgery, even by open thoracotomy. Cosmetically speaking, and length of incision, the differences are minimal. And shoulder function is altered, sure, by posterolateral thoracotomy, but not by muscle-sparing thoracotomy. And now, if we want to discuss the survival rate, I don't believe it is related to less immunologic depression by VATS, but only demonstrates that the stages of the disease were not the same by VATS and by open thoracotomy. Finally, according to different teams experts in VATS lobectomy, there is no significant difference at 6 months. We are obliged to regret not having any randomized trials demonstrating objective advantage of VATS lobectomy over open thoracotomy. The scientific documentation is made up of retrospective comparisons of non-concomitant series and non-comparable tumors. We equally regret the frequent absence of information about the rate of intraoperative conversion and the criteria for choosing VATS versus open surgery. For surgeons very involved in VATS surgery, they say there are some absolute contraindications for VATS major resections. The first is the inability to tolerate single lung ventilation. The second, an established N2 disease. The third, a T3 tumors. And when a sleeve resection may be planned. There are some relative contraindications: previous surgery or pleural adhesions, prior irradiation to the hilum, fused interlobar fissure and established N1 disease, and for many surgeons, a tumor size more than 4 centimeters. When one reads the literature on VATS lung cancer surgery, no complication exists. However, as a practicing surgeon and representative of the court, I have provided legal expertise and discovered some major complications that have not been reported. They are the following: air embolism in the left heart, followed by cardiac arrest and resulting in the death of a young patient. Major bleeding, which necessitated a conversion to open thoracotomy and the death of the patient. I would like to stress on the fact that even for experienced VATS surgeons, a low threshold for converting to an open procedures must always be maintained whenever one is faced with difficulties. The basic principles of safe surgery are under no circumstances sacrificed for the sake of maintaining a minimal access. Now, what about anatomical segmentectomies? I attend many meetings, and sometimes I see marvelous things. I see a segmentectomy, but the segmentectomy is performed using staplers and not in the right plane. Sometimes I see VATS pneumonectomy, and in fact, it was possible to do a sleeve lobectomy, even at the Society of Thoracic Surgeons some years ago. There was the presentation of a video. The patient had a chemotherapy, an induction chemotherapy, before performing a resection, and the resection was possible before the induction therapy by a sleeve, arterial, and bronchial resection. And I see that to perform VATS, the surgeons do whatever they want. And I am not sure that it's always the advantage of the patient. To do a segmentectomy, I learned, and it was the work of my life, because I have not performed only in my life exceptional procedures. I have performed a lot of resection for lung cancer, and I cannot accept that the standard operation for early stage lung cancer of 2 centimeters, the standard operation is not only the lobectomy. Segmentectomy sometimes for the left lung, for example. Sometimes culminectomy, bisegmentectomy have the same prognosis as a lobectomy. But how to do correctly a segmentectomy using the VATS procedure? I think that the segmentectomy performed through an open thoracotomy using the fingers to do that, to be sure to be in the right plane, is better than a segmentectomy using the stapler in the without respecting the correct plane of anatomical lungs. And what about the associated mediastinal surgery? How to deal with the mediastinal vessels, how to deal safely with the pericardium and the heart, how to do a carinal resection, how to resect a part of the spine for surgery of lung cancer, and it's not exceptional to do extended surgery in lung cancer. And what about now about the oncological safety of surgery? The bronchial margins are more difficult to examine when you have put staples on the bronchus margins or on the vascular margins. I think it's easier to examine the margins without the staples at the level. And the hilar nodes. The hilar nodes are not easy to correctly resect using the VAT surgery. And the quality of the lymphadenectomy is not the same using VAT surgery and open surgery. The subaortic nodes on the left side are not easy to remove, and the left laterotracheal chain, it's not easy. And when you read the literature, the N1 and the N2 upstaging by VATS is not the same as using open surgery. And I think that perhaps for lung resection in non-small cell lung cancer, that's it's a good thing to do a wedge resection. And for 2 centimeter size lung tumors, peripheral lung tumors, perhaps the VATS is the same. For pneumonectomy, I think it's a mistake. And indication could be a mistake. For chest wall resection, I don't understand why people try to do the lobectomy by VATS, and after that they remove a large part of the chest wall. It was easier to resect the chest wall and to do the lobectomy through the defect in the chest wall. But they love that. They love that. And probably they have a lot of time to work. I have not. In my department, we operate 2,200 patients a year, and we have not the time to do this kind of mistakes. I think it's a mistake. And as I said, I accept lobectomy for small T1 N0 tumor, but probably there is a difference in the prognosis of very small tumor of 1 centimeter and tumor 3 centimeters size. It's probably not the same disease, it's probably not the same prognosis. And survival is not better after that surgery. I cannot believe that. And the problem is, for that surgeon, you want to increase your activity in lung cancer by using VATS lobectomy, but perhaps for small tumors, 1 centimeter. Are you sure that it's better than stereotaxic radiation therapy? You have not the response. You cannot say that. In my hospital, we wanted to start a new program. It was to compare in small tumors wedge resection associated with lymphadenectomy with radiation therapy, stereotaxic radiation therapy on small tumor. We have not the response, but I am not sure that for a 1 centimeter size tumor, the right solution is to remove one lobe. What do you do when the patient will have a second tumor? And I would like to finish by general considerations. Even in expert teams, the type of surgery for a patient cannot be guided by the technique on the mode, but only by the patient's best interest. I learned in my life that the skill in surgery, it's not important. What is important is to do the best operation and to teach the young surgeons. And I think it's probably easier to teach the young surgeon by open surgery than by VATS. VATS is probably an excellent alternative to thoracotomy in very small, non-small cell lung cancer, but only in this case. And it may be dangerous to extend the indications too far in order to perform a trendy surgery requested by patient and to yield to fashion. And another general consideration is it's a mode. That's it's a lot. In all the thoracic meetings presently, people speak of VATS surgery. 10 years ago, it was mediastinoscopy. Before chemotherapy, after chemotherapy. But we have seen 20 years ago, 25 years ago, it was written in New England Journal of Medicine that all the lung cancer have to be operated on after an induction therapy. Now we know it's false. Nobody does that. 15 years ago, the mode was lung volume reduction surgery. It has failed. Nobody does lung volume reduction surgery now. And there was another mode when I started lung cancer surgery. It was the adjuvant radiation therapy. Nobody now does adjuvant radiation therapy. It was the same thing. People advocated single lung transplantation. Now we know it is a mistake. Double lung transplantation is required. Beware of patients in surgery. And my conclusion is modern surgery must be as less aggressive as possible. And research for less morbidity and mortality is essential. But we must keep in mind that surgical or oncological safety and lung parenchyma sparing must be more taken into consideration than cosmetic, pain, duration of hospital stay. And the massive development of VATS in non-small cell lung cancer surgery seems motivated partly by commercial cell considerations and not always by proven advantages. Thank you.